In this technical note, we describe the posterior bony Bankart bridge technique for treating posterior bony Bankart lesions. The patient is a 19-year-old college football player with several year history of recurrent left posterior shoulder instability. Imaging demonstrated a posterior bony Bankart lesion with an associated glenoid cartilage defect and an anterior labral tear. Patient is placed in the beach chair position and examination under anesthesia demonstrates a grade 3 posterior load and shift without spontaneous reduction. Diagnostic arthroscopy demonstrated an anterior labral tear and a posterior bony Bankart lesion with glenolabral articular disruption. The anterior labrum underwent gentle debridement with a shaver from an anterior-superior portal, and the extent of the labral damage is evaluated. An anterior-inferior portal of the upper border of the subscapularis is also made with insertion of an 8.25 mm cannula. The anterior labral tear is then repaired in standard fashion with a 1.8 mm knotless fiber tack anchor starting from the inferior labrum. The arthroscope is then moved to the anterior superior portal to view the posterior bony Bankart lesion. Using an 18-gauge spinal needle for localization, a posterior inferior portal is made approximately 4 cm distal to the posterior lateral corner of the acromion, and an 8.25 mm cannula is placed. Appropriate position of this portal is essential. The lesion is then debrided with a shaver and meniscal biter to create a smooth bony surface for healing and ensure a stable cartilage interface. The posterior capsulabral tissue and bony fragment are elevated from the posterior aspect of the glenoid to allow for adequate mobilization for repair. A microfracture of the subchondral bone within the cartilaginous defect on the glenoid surface is performed with a power pick to promote fibrocartilaginous healing. Next, a drill guide for the 2.4 suture tack anchor is then inserted through the initial posterior portal and drilled medial to the bony Bankart lesion into the non-articular surface of the glenoid. The drill guide is then translated laterally around the lesion. A 1.8 knotless fiber tack anchor is then drilled into the articular margin of the posterior glenoid. A straight crescent suture lasso is then passed through the capsulabral tissue and the repair stitch is shuttled using a nitinol wire. The repair stitch is then shuttled through the anchor and tensioned appropriately to reduce the posterior bony Bankart lesion to the posterior aspect of the glenoid. A second 1.8 mm knotless fiber tack anchor is then drilled into the superior aspect of the glenoid defect. A suture lasso is again passed through the capsulabral tissue and the repair stitch is shuttled through the anchor in a similar fashion to the inferior anchor and provisionally tensioned. The repair sutures of the two knotless fiber tack anchors should not be cut until the end of the procedure, as these may be sequentially tightened to provide additional reduction and compression of the posterior bony Bankart lesion. The sutures of the suture tack anchor are then placed in a 2.9 push-lock anchor at the articular margin of the glenoid defect between the two fiber tack anchors, creating a compression across the lesion. The sutures are then cut and the two fiber tack repair sutures may be additionally tensioned to provide additional compression. The sutures of the fiber tack anchors are then cut. In this case, two additional superior 1.8 mm knotless fiber tack anchors are then placed to reinforce the posterior superior capsulabral tissue. Additional anchors may be placed as needed, depending upon the injury pattern. The repair construct is then evaluated and the shoulder is dynamically assessed under direct visualization, demonstrating restoration of posterior stability to the glenohumeral joint. Our rehabilitation protocol is initiated directly post-operatively.